Great. How many of you here do ultrasounds yourself? We got a handful of folks, okay. And you're doing venous now? Okay, excellent. So what I'm trying to do here is, I think we have a half hour, am I correct, Pat? Dr. Thorpe, you have a half hour, 30 minutes?
You have 30 minutes.
Okay, so in the 30 minutes, I'll try and show you, one, when you see a patient, how you're going to approach this and how you got to confirm this with ultrasound. So from a clinical point of view, what is the pathophysiology? What are you treating? And how do you come up with the diagnosis that there's superficial venous insufficiency and venous hypertension? The second aspect of ultrasound, which is very important, is that if you don't have the right imaging and the right findings, insurance companies will not pay you, and Medicare will not pay you. And you've heard the word reflux 1,000 times. Every insurance company has their own policies. They have what they call LCD, local carrier determination. And depending on what their policy is, if you don't fit in that category, they will deny it. So to start with, this young lady here, she's 21 years old now. It's very unusual to have somebody at 21 when they have symptoms. So she actually is already being treated by Dr. O'Neill here of 6 months ago. So when she presented with the left leg, she had swelling and pain in her legs, especially after standing for a long period of time. She had an ultrasound then on the left side, and she had reflux in the saphenous. So I'm going to take a couple of minutes to tell you my approach to this when a patient shows up. So the first is, what is the aim of treatment? With normal legs, the pressure in your legs when you're laying down in the superficial venous system is 0. As you sit up, it goes up 0 to 20, and then as you continue to stand and sit, it'll go up to 30 to 40. That's why compression garments tend to have the 20 to 30 or 30 to 40 compression graduated. If you get venous hypertension, which comes from venous incompetence of some valve, now you have superficial venous insufficiency, leading to venous hypertension, which then leads to the manifestations of either swelling, pain, an ulcer, or SEEP1, which is cosmetic. So once you have that clinical objective, now with ultrasound, I'm going to try and find it. So a principle here is you always examine from the bottom up as clinical exam and treat from the top down. And the other important thing is you want to have the patient standing for a while, because you can take a very incompetent vein or valve with severe reflux, make them supine and make it completely normal. So you can have a patient who's borderline, they have symptoms mainly at the end of the day, but you do the ultrasound early in the morning, they're kind of dehydrated, they haven't been standing around, you'll get a normal result. So if you have them standing for a while, make sure they're well hydrated, especially towards the end of the day, you tend to see the venous hypertension and the reflux a lot more. All right, so now I'm going to examine her right leg. Her left's already treated, so we're going to kind of ignore that for a moment and see how we're going to approach this. She has some pain and swelling in her leg. Now when I examine it, I don't see any visible varicosities. I don't see any edema right now. She told me, I just met her a few minutes ago, and she told me that she hasn't been standing for long. I made her drink some water anyway, so make sure she's well hydrated. Just like, with the IVC, if you're somebody dehydrated laying flat, the IVC will be flat. You stand up, it'll engorge. The same thing happens with all veins. If the room is cool, you can get some venospasm, versus if you're in a warm environment, sometimes you even keep warm blankets in the room, even when you're getting access and doing the procedure. So this is a Siemens machine. I'm touching it for the first time, but I think we'll manage. And obviously I have a tech who does this. We do several a day. And I'll go in and look at it as I need to. So I have them standing, of course. Usually, the other important thing is when you do the standing venous ultrasound, if you just leave them standing like this for a while, I've had patients just go boom, bang, land on the floor. So you got to be careful with that. You have stands that have a handle and like a rail, etc. There are different types available there. So we're obviously looking for saphenofemoral reflux first. You look at the saphenous vein, that greater saphenous vein, which goes all the way from the upper thigh junction all the way down to the ankle. Along the way, there are perforators. So we want to find some of these perforators. And some insurance companies only say we'll pay for saphenofemoral reflux. On the other hand, you could have a competent saphenofemoral vein junction, and the vein over there not refluxing, but a large perforator from the deep refluxing in the mid-thigh, and you have completely incompetent saphenous with reflux, with hypertension, and manifesting down the leg. So I usually, when I see the patient, will start from the bottom up, and as I'm looking at this, already. So the first thing I'll start to do is find the saphenous. So I see this greater saphenous. This is below the knee as I'm looking at it. Now, when your ultrasound tech does it, they'll go segment by segment, measure each, mark it, and look for reflux and measure the reflux. As a physician, what I want to do is quickly first, if I'm examining them, get an idea of what's going on and come up with a diagnosis. By clinical assessment, she's a CEAP1. She's normal. But there are some very early signs which would tell me why she had this on the other side. So you see this branch up here at the very top. I think we have a lot of light there, so it's, as you can see, that's the vein right there. That's not the saphenous, that's just a branch. It's under the skin. But as a normal person, you shouldn't have that. So I know that she has some mild varicosities, if you would. And there you see the saphenous within the, all right, okay. This here is the saphenous vein within the fascia. As you can see, the Egyptian eye, the fascia on the top, fascia at the bottom, this is below. And you see there a perforator coming in from the deep into that greater saphenous, and this is below the leg. So we know that she has some perforators that are already incompetent just based on the size. And as she stands, some of this will get even bigger and longer, and I compress, so I know that definitely is the vein. So I'm going to now map this up and down, and I'm going up. I saw some other branches going out. I'm going up the thigh, and you saw another small branch go up, but not very big. Now imagine after a while, if this venous hypertension continues, this will get bigger. So now I'm in the mid-thigh, and you can see the saphenous vein within the saphenous fascia. As we go up further, I'm getting closer to the junction. Here's a branch. This is not a perforator. This is going to become the posterolateral branch, or it's going out. Often here you may see a duplicated saphenous vein. It's important to kind of get an understanding of if it is within the fascia, that's the saphenous vein. You could have a branch outside that is not the saphenous vein, but you can still have reflux within it. So you can see this branch is going across as it goes up, and that's going down in the back, this posterior medial. Okay. Now I'm going up further, and I'm going to go up towards the junction, and I want to see the saphenofemoral junction. Pull that up for me, please. Let's pull that up a little bit. Okay. And that's the saphenofemoral junction here. I'm going to play with the, okay, now she is standing. You can see some of the flow back and forth. Could you hold your breath and bear down? And you see there's mild incompetence there. I'll show you with color. Now breathe. Okay. Switch on color here. Do the same for me, please. Hold your breath. Breathe. Now you saw a flash of color as it went back. That's a little bit of reflux. Now she does not have a lot of reflux. Sometimes you'll just see the valve wide open and this flowing back and forth. You can see with breathing the flow forward, but not a lot of flow backwards. You occasionally see a flash going back. All right. Now I want to document if there's insufficiency here and reflux, so I'm going to now put in my Doppler caliper here. And she does not have a lot of reflux. It is hard at the junction to do kind of squeeze and get the reflux, if you would. You can try it in the calf, and she really doesn't have reflux at this point. As I squeeze the calf, nothing flows back. I squeeze the thigh, nothing goes back. Can you kind of cough for me for a second? Okay, again, nothing much there. So actually on this side, her saphenofemoral junction is competent. Try to do it one more time. Can you take a deep breath and hold again? And now breathe. And you can see the valve's competent. There's no flow going back from the common femoral vein into the saphenous vein. You can occasionally see the anterolateral branch, which is going down here. Now, sometimes I've seen folks mistake this for the saphenous vein, especially when it's very large. But you want to call it the saphenous, you have to see the saphenous fascia here. So as of this point, I know that a saphenofemoral junction is competent. And as I come down the saphenous all the way up to the knee, again, the size is reasonable. I'm going to measure that. And it's about half a centimeter, 4.6 millimeters. Now, different insurance companies are going to ask you for different criteria. They will definitely look for the size. Some will say if it's less than 5, it's not abnormal. Others will tell you the size doesn't matter, but the amount of reflux matters. More than 500 milliseconds of reflux. And some, United is the worst of them all, they will find any excuse whatsoever not to pay you. So one of the things I've had to call them on these peer-to-peer calls. And I had a patient who it was 16 millimeters, 1.6 centimeters. So now we've got a fairly large saphenous vein. We've got reflux. Now they tell me in this plan, as of their policy, if it is more than a centimeter, they don't approve the procedure. And they would rather pay for a ligation or whatever else, but they disapprove the study. Some will pay for ablation, laser. Some will pay for RF. We've had recently, I do a lot of microfoam, which is Varithena, and we crosswalk that to ablation. Sometimes they'll approve that, but they won't approve the other ones. And what I learned is most of these people who do the peer-to-peer review are doctors sitting in front of a computer making a couple $100 an hour, and they open your chart, they get on the phone, they read the document that they have. If you say the right words, and especially from their LCD, which is always online, if you know their plan, if you meet their criteria, they approve it. If you don't, and they type in the computer and they say approved. If not, they say, sorry, doc, it doesn't meet, and they deny it. So why am I telling you this? It's important first to say, is there a problem? So with her case right now, she doesn't really need any intervention. What she really needs is some compression garments. Where at the ankle, the pressure should be about 20 to 30. At the knee, about 20. She really doesn't even need high stuff. I see no visible varicosities. I don't even see telangiectasias or anything. So from that point of view, she's fine. But at the end of the day, when she stands, she tells me that around the ankle, she feels some pressure, puffiness, and some swelling, which is, again, there's no pitting edema or anything like that. Any questions so far? Okay, sure. All right, so here's the saphenous. So what I'm showing you here, the upper line here, that's the fascia on the top. Let me go down a little bit. So fascia here, and that's the vein in the middle. As I go down, you'll see now, you see that over here, something came out across the fascia. That's a branch going out. Now, if there was significant reflux, which therefore means higher pressure, this branch here, the one where the caliper is, will get large. And then that's one of the branches. You know, some people do phlebectomies, etc. I wouldn't be doing it on this one. This is close to normal. This is very mild, if anything. Now, I'm going to show you the lesser saphenous. Did that answer your question? Okay. So it depends. So you can put a cuff. There are devices available for that. But if there is significant reflux, they just go and you'll see the flow right back. And you know, sometimes you just squeeze the calf, some blood goes up, comes right back down. Because remember, there are 3 pumps in the leg. You have the plantar pump, you have the calf pump, and you have the pump in the lower leg, which acts like a piston. So when you'll never see ballerinas with varicose veins, unless they have congenital valvular dysfunction. The reason is they're very good calf pumps. And now there are devices available that are just on the plantar surface, and every few seconds, but for 2 or 3 seconds, they'll squeeze the plantar pump. So if you teach the patient to get that pump active, the blood starts flowing out. So when you squeeze the calf, blood will go up. And when you release it, you should see reflux. And then you can kind of measure that accordingly. Let me show you quickly the saphenous vein as well. So here's the saphenous. Now, when I first measured her a few minutes ago, this was much smaller. As she's standing, it's getting even bigger. Now, that's just normal physiology. Now I'm right behind the knee. So let me start lower down. And you see here, I'm starting right almost near the ankle. That's the fascia. That's our saphenous. Here's the upper. Here's the lower. As I go up, now you see there's a branch coming across. Now it's not going deep. It's going lateral, and then it's going out the skin. So that actually is going up to the skin. So that's not a perforator. What I'm going to look for is a perforator. There's a small perforator here that just went by right there. Now that's competent. It's not refluxing. Is it small? But as I go up, you just see another branch which is not connected with the saphenous. As you see right here, going through into the deep, into the muscles. Oftentimes you will not have saphenous reflux, but that perforator could be refluxing, and I suspect she is very mild. So I'm going to try and do longitudinal, and you can see it go through the fascia right there. That's why they call it a perforator. It's perforating through the fascia, right about here. I'm going to try and get some color on this. I squeeze and I leave. So you saw just a flash of red coming back. Blue is when I squish and the blood goes out. I leave. There's just a small flash. That tells me it's not a lot of reflux, at least not significant for treatment. So I'm going to try and see if I can get let me find it in good. All right. Again, not a lot of reflux there. Just a small flash, and within 2 microseconds it comes back to normal. I'm going to try and do this one more time. So in very abnormal veins, you can see this up to even 2 seconds. And you can see this particular blip up here that came up right there for a second when I squished. That's the blood going out, and almost immediately the valve closes, so there is no reflux in that branch either. All right. So now I'm following that saphenous up further. And now at this point should be going and diving back into the popliteal vein. You can see it going down, and there it dove into the popliteal. And you look for reflux at this junction here. Now it's important that you always work with a machine that you know well. This is brand new for me, but they all at some point have the same principles like any little car. Without color, you see the flow going forward. There's a little back and float there. Just check with it, color. I'm going to squeeze a calf. And you can see when I squish, blood goes back, but when I leave, there's just a small flash of red. That tells me there's not a lot of reflux and that valve is competent. And this is where it's connecting the popliteal vein. So the lower part is the popliteal vein, and upper is the lesser saphenous, or the short saphenous going in. Occasionally, you'll have this branch going up the thigh as the vein of Giacomini, and then comes up and connects with the saphenous. Any other questions? So I can address them. How am I doing on time, Doc?
I think your time is over.
Okay. I'm just having a good time doing this and talking away. So. Thank you. So at the end of this, you want to get an idea of, geez, are my symptoms correlating with the ultrasound? So ultrasound is your eyes under the skin, and you also get a perception of flow. I still have 10 minutes. Okay, I thought he really meant I'm done. Okay, but I'll see. So one of the key things here is to be able to correlate what's happening with the clinical findings. So if you have an ulcer, for example, and the saphenous junction is competent, what does that mean? You will not get an ulcer unless the pressure is high. So where's the pressure coming from? So you follow. So in forensic accounting, they say, follow the money, you'll find the problem. Here. And mild. So if you put on SEEP classification, her symptoms are not even SEEP 1. Now, if I stand all day, my feet are going to hurt, right? So hers as well. But she has some very mild early disease. So when I have a young 21-year-old come into my office, and there's nothing cosmetic, I teach them good habits, a lot of walking, Fitbit, but also they get onto a elliptical. They keep their ankle fixed, and they just move their thighs. They do not activate the calf pump or the plantar pump. So it's better for them to walk heel to toe, activate the plantar pump, activate the calf pump, get the circulation better. I spend a lot of time teaching them about compression sleeves and how to kind of use that with that in terms of staying fit and healthy. You teach them about yoga, different postures that they can do where the legs are up so that you help kind of the pressure go down at least for some time. But if you had a patient with wounds and the saphenous junction is competent, now where is the pressure coming from? If you follow the pressure, you will find it to either a large perforator that has to be coming from there, or all the way up the saphenous. If it's not the saphenofemoral, it's some perforator along the way. And you want to shut down the pathway of where that abnormal pressure is coming from. So we actually draw a diagram and mark where that is going through, and then start treating from the top down. So if I have a patient with a SEEP6, big ulcer, saphenous junction is incompetent, I'll do the saphenous first. Then I'll come down, there's a big perforator, I'll shut the perforator and whatever branches are feeding around the area. If it heals the wound, great. If it still hasn't healed it, I see where else is it coming from. So when we do the ultrasound, this is the part I want to stress, it's very important to create a plan. I think the pressure is coming from saphenofemoral, perforator of the thigh, perforator of the calf, one of the ankle, and then we give the plan to the insurance company and get approval for all those as a plan and then work our way through it. What doesn't work is if you just say saphenofemoral, you just ablate the saphenous, nothing has changed in the leg, now you ask for another approval to say, why do you want another approval? And the patients get disappointed because they haven't seen any difference. And so that's kind of the mechanism of it. So the pathway we follow there is clinical exam, ultrasound. If I have some questions, I'll check it myself, and then the ultrasound tech does a detailed study, both sides. The other important question is always check the deep system to make sure there is no evidence of any kind of obstruction, of any DVT. Now, you may have old DVT, a little thrombus somewhere, but there's no obstruction, no big deal. But if there's evidence of obstruction, then your superficial pathway is really a collateral channel. So I had a 30-some-year-old show up in the office, actually did a meeting in Chicago, and one of the reps that was giving us the equipment said, I need to send you one of my relatives. He shows up. And I was appalled to find that somebody had gone and ablated all his superficial system when actually had DVT. And he had wounds, so instead of getting better, he actually got terribly worse. So then we had to get him back and try and open his deep channels that were fluid and give him time with compression, et cetera, to kind of open up. So always check the deep system as well as what's going on. Another important point, here you have a 21-year-old who's absolutely normal, but you have an old diabetic who's got wounds, some arterial, some venous, you don't know. Always check the arterial circulation as well. If there's evidence of PAD, treat the PAD first. But if there is PAD and you're not treated it, do not ablate anything because the tissue is already ischemic. You actually make things worse instead of better. All right, any other questions? Anything technical with the ultrasound in terms of showing something, mapping something? Anybody? Yes.
I occasionally see patients that are younger and they have small caliber GSVs with significant reflux, and the patient has significant symptoms, but the diameter of the vessel is still very small.
So then I know, because if you look at a 6'5", 20-year-old versus a Asian 4 feet 8, 20-year-old, their veins are going to be small. They could still have reflux. That's the insurance company's trick. So then we appeal it. We explain it to them. Often, if they have a good PPO plan, they'll say, "Fine, you got it." Sometimes patients pay out of pocket, and we actually put plans for them together. Point is, if there is reflux, there's hypertension, you treat it. So just the size, because most studies are done in Caucasian groups, and they are all bigger people. And so that doesn't work, so we match it, and we'll make sure that if it's smaller, it's still as long as there's reflux.